Hello, everybody. Thank you guys for joining on to the webinar today. I'd like to introduce you guys to Dr. Mark Linzer. This is our second physician burnout webinar. This one is going to be more focused on clinical providers, more so administration and management, how to improve the provider and patient experience within your own system or clinical setting. Dr. Linzer, sorry guys, I'm a little sick. Dr. Linzer has had extensive years in practicing medicine, and he's been highly involved and an active and effective clinician, teacher, and researcher on this subject. He has had over 100 scholarly publications in peer-reviewed journals. He's received numerous teaching awards from students and residents and colleagues of his own. Dr. Linzer's area of interest, as you can tell, and relationship is between primary care work conditions, stress, burnout, and without further ado, here's Dr. Linzer. I'm sure you guys will enjoy his presentation.
Thank you very much, Bernice. Go well. And thank you very much, everybody, for joining. And we chose to have the open mic format today, so since it's a small gathering, anybody wants to say something, just say it, raise your hand, send a note, or just speak. So we'll try and keep it informal, and I'm going to try and make sure there's plenty of time at the end for discussion. So, in here. Let's see, I've got to use this one. No conflicts of interest. Our research is supported by the Federal Agency for Healthcare Research and Quality. Can you all hear me there?
Yes. Can you hear me?
It sounds really...
No, I'm not hearing anybody.
Okay, well, it sounds like you can hear me, so I will continue.
No, right now I'm not hearing. Right now I'm not hearing you.
Tricia, advice?
go ahead and just go. I know she can hear us. I think she's just having some issues with her mic. She's joining us with a headset. So
okay, is that Deborah?
Yes.
Okay, then it might be good for sending notes and other things like that for communication.
Exactly, yeah. Deborah, if you have any problems or questions or anything, you can go ahead and send notes, and then we can address it that way. But I will go ahead and keep that line muted at this time.
So the three things I was hoping to cover today, again, mainly focusing on clinician leaders or administrative leaders, is to talk about what a healthy work environment might look like and how to create one, discussing some ideas of self-care to protect against burnout, and then talking about collaborative approaches to develop and maintain a healthy work environment. Burnout continues to be in the news. There was an article in the New York Times I was interviewed for several years ago, and you always worry when they talk to you for 45 minutes and take one quote, but they picked a reasonable one. It will take real structural change for doctor satisfaction to improve. Fortunately, the data show that doctors are willing to put up with a lot before giving up. We are a very resilient and hardy group, but it's also a very stressful profession. So important to understand that. A recent article in the Archives of Internal Medicine was covered by the New York Times, USA Today, the Atlantic Monthly, from Tate Shanafeld's group at Mayo Clinic, showing nearly half of physicians report burnout symptoms in 2012. Some of the research base, our work started in the late 1990s with a physician work-life study. We surveyed 5,000 U.S. physicians, and among the findings was that satisfaction was promoted by long-term relationships with patients, that time pressure during office visits diminished satisfaction, stress was related to a lack of work control, and burnout was predicted by work-home interference. And I'll call attention to the lack of work control variable. We'll keep coming back to it. It's so crucial. But one thing that's big on the horizon these days is standardization of work. So everybody's doing the same amount of work. And you can imagine that one thing that does is it takes away control of the workplace. So watch out for that one. This is the burnout model that we published in the American Journal of Medicine, 2001. There are several background variables on the left: gender, age, children, solo practice. I believe, Kathy, you mentioned you had several smaller practices. Solo practice was associated with more burnout. Academic practice was not protective. Things were a little bit worse in terms of burnout because of multiple activities. And work hours. But really, work hours by itself is not, in and of itself, the determinant. It's the three mediators in the middle: work control, work-home interference, and home support. And you can imagine how somebody can work 70 hours a week but have everybody managed at home. Somebody's there taking care of the kids. They have total control of their work environment. They will not burn out. You can imagine a 40-hour-a-week single parent trying to get the kids to child care. They have no control of that last patient visit at 4:40, and they will burn out very shortly. Work-home interference is a very important variable. It not only was related to stress and satisfaction that lead to burnout, but it actually goes directly to burnout as well. So you need to understand the challenges that people face in terms of work-life balance. We then were funded by AHR2, the Federal Agency for Healthcare Research and Quality, to do MEMO. MEMO is minimizing error, maximizing outcomes. And it was an attempt to align physician and patient outcomes. We looked at the impact of the work environment on physician outcomes and patient outcomes. 119 clinics, 400 docs, 700 patients, 1,700 patients. And the main goals were to determine the relationships between the work conditions, the reactions by physicians, and patient care quality and errors. The MEMO conceptual model is very similar to the burnout model that we showed. The structure and culture of the workplace, along with workflow, policies and processes, and patient demands are on the left. Physician reactions are in the middle. Patient outcomes are on the right. If you look, you will see an arrow on the bottom that goes directly from the workplace characteristics to the patient outcomes. Well, I have a little pointer. There we go. And that arrow is associated, shows that there is a direct connection between workplace adverse work conditions and patient outcomes. Physicians will actually try to do everything they can to prevent adverse work conditions leading to adverse quality of care at their own expense. We'll get to some of those data right now. So to measure quality, we had up to 6 patients per primary care physician with diabetes or hypertension. We also looked at patient satisfaction and quality of life with a patient survey, and disease management with chart reviews. Errors were determined by confidential chart reviews for errors in processes of care, wrong medications, misprevention activities. Some of the results: 50% of doctors needed more time for visits. About a quarter were burning out or burned out. Almost a third were moderately likely to leave their job in 2 years or more than that. There were very strong relationships between work conditions, and in particular, time pressure, lack of control, chaotic environments, and organizational culture, and physician outcomes, including satisfaction, stress, burnout, and intention to leave the practice. So keep your eyes on intent to leave. That's the retention and recruitment variable. If people are intending to leave the practice, this is a big challenge. Burnout leads to a lot of things, but one thing it reliably leads to is leaving. In addition, many patient care outcomes were linked to the work environment. So, for example, if doctors had moderate to high work control, they had higher diabetes care quality. And if doctors had more time pressure during visits, then they had lower overall quality and poorer care of their hypertensive patients. If there was a high emphasis on information and communication, overall quality was higher, and there was better hypertension care quality. And a particularly interesting variable, values alignment between clinicians and leaders, led to better diabetes care, substantially better, and fewer missed prevention opportunities. This is our instrument called the OWL, the Office and Work Life Measure. It summarizes, gives you a snapshot of what a clinic looks like in terms of the key variables. This is a mock owl from a particularly challenging setting. Work control, what percent of your doctors felt that control was high, 25% in this clinic. Then you give comparison clinics on the owl. So 68% of comparison clinics felt they had high control. Job satisfaction was only high in 37% of doctors in this clinic, 68% in the comparison group. Values alignment was low, only 40% had strong alignment versus 70%. In other clinics, chaos was high, 65%. Time pressure was high, 65% of docs felt they had less time available than needed for quality care. Stress was high, and 80%, burnout 50%. So this is a challenging place to be. Intent to leave the practice, 65%, intending to leave within 2 years. This is from the manager survey for the OWL. What sort of technology is present in the clinic? In this clinic, the electronic medical record, 100% of the aspects of an EMR were present, including computerized lab results and 75%, computerized patient notes, 75%, and so on. Patient communication via email and MyChart was present. 100% of the docs said so, or the managers said so. Staffing ratios were on the low side, 1.2 of support staff versus provider staff, 1.7 in comparison clinics. And exam rooms were 2.2, but that was relatively low compared to the comparison. I mention this because an abstract we're going to present at our national meetings later this month in Denver show that the number of exam rooms available are directly correlated with quality of care. If the exam rooms fall, the quality of care falls as well. There were certain bottlenecks to care. In this case, phone access was felt to be a bottleneck, follow-up appointments, patient check-in and check-out, and so on. So this is, the OWL is a way to look at your clinic and say, what have we got going in terms of structure and culture? And higher up on this first page is, how do the clinicians feel about working here? The next page of the OWL is all about how do the patients feel about coming here, and what are the quality of care measures? And then you relate these OWL measures that we just looked at to the quality of care measures for the patients. Now, our current grant, called Creating Healthy Workplaces, is a randomized trial of quality improvement interventions to improve work conditions and care quality. We've been studying 34 clinics, rural, urban, and inner city. We use the OWL to measure work environment and patient outcomes at baseline, and after 6 to 12 months in intervention and control sites. 17 clinics were randomized to interventions. So the first thing we found is that the data were incredibly powerful. Clinics that were shown their OWL data really sat up and took notice. It just stopped people in their tracks to say, oh my gosh, 50% of people burned out, 2/3 getting ready to leave, nobody highly satisfied, what's going on? And the data spurred meaningful conversations and movement towards solutions which had not happened before. Some of our research technicians have told us that they thought activated managers may be a key link to clinic transformation. So when the managers engage in these data and look to find improvements, it really can help. So just to mention, for job satisfaction, there is a business case here. At Harvard's Business School, stocks rose 147% when employee satisfaction rose. In 8,000 businesses, productivity and income were tied to employee satisfaction, not customer satisfaction. And at Sears, when employee satisfaction rose 4%, sales increased by $200 million. And then customer satisfaction would rise. So paying attention to these variables is not just something someone might do because they care, which would be a good enough reason, but it also is a good business thing to do. There are many outcomes of dissatisfied physicians. Certainly burnout is a big one from our model we presented. Turnover, $250,000 for a departing physician, and that's from 1999 data. Instability with larger patient loads for the remaining providers. reduced access to care, satisfaction of the patients, reduced medication adherence, and patients leaving the practice. So burnout is a long-term stress reaction. It's quite common, 20 to 40%, and a recent study said as high as 46%. It's also higher in medical students and medical residents. Medical residents associate burnout with perceived errors. It's 60% higher in women physicians than men. And the three key mediators that we talked about earlier, worth reminding, are home support, work control, and work-home balance. These are the key factors that prevent burnout. So this model, developed in the social science literature in 1981 by Karasek, shows the demand control model of job stress. It's very straightforward. And it really just started with demands being balanced by control. And the idea was if you had this imbalance, even high demands could be balanced by control. But if you didn't have control, the seesaw goes up and the stress rises. And the study was repeated several years later. This was in Swedish workers looking at the variable of support and found that support can also balance demands. So you've got control and support keeping your demands in check. So the bottom line is support and work control prevent stress. If you remove control, standardize everything, and if you don't act in a way that is felt to be supportive by the people working for you, no matter what your demands are, the seesaw goes up and stress is high. In terms of gender differences, we did a study comparing U.S. data with Dutch data. There was no gender difference in burnout in the Netherlands, and it's 60% higher in women than the U.S. The two factors we found were important is fewer work hours in the Netherlands by women. So Dutch women physicians, 75% work part-time, and Dutch women primary care doctors, 88% work part-time. So virtually universal. And the second factor is better work control in women versus men MDs in the Netherlands. So again, this control variable is very important in modulating the stress of high demands. We feel there's more burnout in U.S. women physicians due to a gendered expectation for listening. Women will choose a female physician 90% of the time. Males will choose a female physician 70% of the time. And yet there are fewer female than male physicians. So there's tremendous pressure to get into the practice of a female physician. And why do they choose a female doctor? They want someone to listen to them, in addition to managing all the complicated medical problems. So the woman doctor has all these other things loaded onto their visit, but the visits are no longer than any other visit. They're still short, and the time pressure is higher. So time pressure is higher, chaos is higher, the pace is faster, and there's more challenge during the visits for women, thus resulting in more burnout. So we presented these data in a couple of environments, general medicine meetings, 2005, and then again at the Eastern Sociological Association meetings in New York around that time, describing not only less values alignment that women physicians felt, but also less alignment in almost all the variables of organizational culture. So it's really important to listen to your women doctors and find out what they're facing and try and accommodate and adjust for it. We have a paper that we've submitted on burnout, dissatisfaction, and the electronic medical record. In the memo study, we look at the relationship between EMR functionality and stress, burnout, and dissatisfaction. Two findings. Burnout and dissatisfaction increased as EMR functions increased. So the more sophisticated, the more EMR functions you had, there was more stress, more burnout, and more dissatisfaction. As the EMR became fully functional, these values decreased, but they didn't go back to the original levels. And they certainly didn't get any better. So transitioning to an EMR is a very stressful thing. The second finding was that in fully functional EMRs, shorter visits were associated with significantly more dissatisfaction, burnout, and intent to leave. So when you have a fully functional medical record, you can't shorten the visits. By doing so, you've got all these data to manage in a very short period of time. The result is dissatisfied, burned out physicians who will intend to leave. Now, one last burnout predictor to mention, career fit. If the percent time clinicians are able to do what they are most passionate about falls below 10%, burnout rises dramatically. So be sure your docs have time, at least 10%, to devote to what they care most about. It's a worthwhile investment because it will prevent burnout and leaving. So now some suggestions. How do we prevent burnout? And then we'll throw it open to discussion. Flexible and part-time work. Leaders modeling work-home balance and valuing the well-being of their clinician partners. Promoting work control. Limiting EMR time outside the office and providing sufficient time to use it inside the office. And in Vivier's paper, Alter Our Culture of Endurance. This is a paper written by Canadian ophthalmologists who saw 40 patients a day, 5 days a week. And I would certainly agree. That is a culture of endurance that is not satisfactory. So, less time pressure, more control. Extend appointment times or offload some of the non-clinician work. The people in Seattle have started using desktop slots doing sessions, so you might have 10 slots for a session, but 8 of those are patient care slots, 2 of those are catch-up times for your computer time. And then if you've been gone for a week, maybe a couple of hours to catch up after a vacation on all those covered in-basket messages. More order and less chaos, maximally utilizing space so you're not crowded. Piloting unique schedules like 7 days on, 7 days off, working evening clinics and weekends, and then being off an entire week with somebody covering your in-basket. Explicitly supporting work-home balance, part-time practice and practice styles, particularly supportive of parents of young children. There's a lot of parents of young children in the physician workplace. The Virginia Mason Clinic in Seattle builds forms, work into practice flow, so as you come out of the room, the MA hands you a form. It's mainly filled in, you sign it and give it back, and it's done. Respecting the life cycle. We published a paper in the American Journal of Medicine, it's quoted down there in very small print, 2002. Hiring float clinicians to cover parental and sick leaves. We showed in a division of general medicine, if you had 20 faculty, that within 18 months of predictable life events, you were down to 18 people at any one time. On average, you're about 10% short. And that work gets absorbed by the rest of your doctors, and they certainly feel it. Building workplace teams to address workflow and quality, not making it a sole job of the doctor or the provider. Building a supportive culture with aligned values, and that means having to ask about values and explaining your own. And taking time to listen. And sometimes no action is needed. Wellness in work life, in our minds, means times to reflect on a challenging case. We start all of our division meetings with a challenging case that we all talk about together. This was written about by Dunn and Arnett in the Journal of General Medicine from Oregon, Portland, project out there. People like to talk about clinical work, not just administrative challenges during division meetings. Are people getting time to exercise? Do they get to eat their meals, or do you have meetings during meal times and not able to eat? Can they get their work done at work? Do clinicians have time to see a patient, listen, provide empathy, attend to quality, and use the EMR all in the amount of time available? If not, it's probably not enough time. Do people have time to huddle with their team? Because their team can really help with all the above things. And are there meetings with leaders to discuss values, direction, and purpose? I tend to try to remind our full-time clinicians that part-time physicians are key. They are hard workers, usually work more than their FTE. They're loyal, connected, and have good morale. Their patient satisfaction scores are high or higher than full-time clinicians. And that when full-time clinicians may wish to go part-time for children or at the end of their career, by that time the part-time docs may be willing to go full-time. So they're a very valuable part of the workforce. And we're almost done here. The mini OWL is our distilled measure, if you will, of the OWL. It's got just 8 questions, but with these 8 questions you can really get a sense of what's going on in your workplace. Overall, I am satisfied with my current job. I feel a great deal of stress. Using your definition of burnout, circle one of the answers below, and anything 3 or higher is considered burnout. My control over workload is sufficiency of time for documentation, which number describes the atmosphere, calm, busy, or hectic, chaotic. Professional values are aligned with departmental leaders and organizational leaders. And those really are the key questions to know whether your workplace is thriving or really having trouble. And we'd be happy to work with you in using some of those measures. So how to get to any of this? One way that some sites have used is to create an Office of Work Life and Wellness, which is a visible site for wellness, with wellness champions in each division, department, or setting. We do periodic brief surveys of stress, burnout, and remediable predictors, focused action plans, and then a role for the managers to oversee the wellness focus and the transformation. So someone's got to watch over this process. And there we have it. It has been a privilege to share our research with you and your group and your team, and we hope it's of some benefit. And we have plenty of time for discussion.
Are there any questions from anybody? You can go ahead and unmute yourself.
Can you hear me?
There you go.
Okay. Mark, this is Virginia, and thank you so much for another excellent presentation. One question I have, do you think there are differences between PAs and NPs as a group compared to physicians in terms of burnout and the variables you point out here?
I've given some talks where we did audience response, and we separated out the NPs and PAs from the physicians and also from residents and other trainees. There seem to be some differences, but since it's only been a couple of sites, it's anecdotal. I think a lot of it would depend upon how integrated and empowered that work group is in the organization. But we did see some differences.
And differences in terms of less burnout possibilities?
Well, again, it depends upon the site. When if people feel connected,
right,
organization, if they feel that their values are aligned, and they have enough time to do their work, then they're okay. But if as a group they are not empowered, not connected, have no say in their work, have no control of their work environment, then the stress and burnout is going to be quite high.
Makes sense.
Dr. Munter, this is Kathy Suvia. Could you go back to the slide that you indicated that 30% of the respondents, or of those 30% were moderately likely to leave within a certain period of time? Could you talk just a little bit more about that? I think that's real significant.
So that's the memo study.
Yes.
Back to the interest in retention and recruitment. So that's this one, I believe.
Yes. And I'm not sure that I caught how many physicians you studied, and was this a study that included rural as well as urban practices?
Thank you. I didn't mention where the docs came from in MEMO. So MEMO had 5 or 6 clinical sites, and we did have a fair number of rural doctors in the MEMO study. Quite a few, actually.
Okay.
So again, you know, intent to leave is sort of on the far right-hand side of the scale. Burnout leads to intent to leave, so then you got to back up a little more and say, so what's leading to burnout and intent to leave? Go back a little further. Burnout model. Here. So intent to leave is all the way over here, past burnout. So before you get to that, you'll get dissatisfaction and stress. And here's some of the key variables. People don't control their work environment, so they can't modulate stress of high demands. If the work environment is not sensitive to work-home balance, they have not got support at home. All of those will substantially contribute to lower satisfaction, higher stress, more burnout, and intent to leave. Solo practice was actually highly associated with burnout and intent to leave. Very strong association. That was published way back from the Physician Work-Life Study, original project that we did, this one. So here's an article in 2000 that would look at some of the issues about solo practice, but it was quite strong. Solo practice is hard. A lot of time pressure, a lot of stress. I mean, you may have some control of your template, but there's just too much coming in.
Right, right. Thank you.
You're welcome.
Hi, Dr. Linzer. This is Alan Meyer, and there seems to be a movement, especially with focus on patient-centered health or medical homes, towards more team-based care, you know, including roles for medical assistants and nurses and behavioral health staff. And I think intuitively it would seem to indicate or lead to a more supportive environment for the physician or provider. I was just wondering if you have seen any studies or research that sort of talk about the impact of a more team-based approach on satisfaction and burnout prevention and things of that nature?
Yep, I'm trying to pull one off my desk. Pulling off my desk at the moment. So, yes, there was an article in the American Journal of Managed Care in September 2009. First author's name is Reid, R-E-I-D, Robert Reid, and the senior author is Eric Larson, L-A-R-S-O-N. And it was a patient-centered medical home demonstration project, volume 15, number 9, page E71 to E87. So that was the original study where they really ramped up some of the variables that we talk about here, gave people enough time, smaller panel size, 4 teams. Watson's got a great table in there about what they did, just a lot of different things that all load up on the burnout prevention variables. And their burnout was lower, their quality was high, their costs were good, quite good. So that was the original study. Now, since then, there's been very little that really measures the clinician experience with the patient-centered medical home, and Sarah Poplow and I are trying to finish up a measure called the CASE measure, the clinician and staff experience with the PCMH, that would help us measure in a very parsimonious way, a very small and short manner, how clinicians feel about team-based care in the PCMH. We imagine it's going to be quite positive, and there's quite a few questions about teamwork. How effective is your team that we got from the literature? So the answer is I think it's going to be very good, but you know, if the team does not take some of these burnout variables into account, if clinicians don't gain some control from the team, if somehow work-home interference is not addressed, it could wind up being problematic.
Thank you. That's very helpful. And I'm thinking, since many of our clinics are already sort of moving in that direction and have strategies in place to kind of become more team-based, that maybe what we can look to do is sort of figure out ways to sort of embed some of this burnout prevention and satisfaction activities, sort of, or just have an awareness that that is also a part of the goal of having more team-based care. It's not just improving efficiencies and patient outcomes, but that really the provider satisfaction needs to be, considered and sort of consciously included in these efforts.
I really agree. So we're not only creating an environment that will satisfy the current providers, it's got to be an environment that's going to attract medical students and residents, the providers of tomorrow, into wanting to do it. And we have to create environments that people want to be in. We have a shortage of primary care providers, and if we want to reverse that, this system needs to do just what you said.
Great, thank you.
Bet. Yes, go ahead.
As most of you, as you know, most of us are involved with community health centers, and would you comment on differences perhaps between community health centers and other practice settings, and also some of your experience of the health disparity issue?
That's Virginia.
Yes, that's me.
Thank you. We have an abstract that we're presenting later this month at the National SGIM meetings in Denver about this. We have a paper we published in 2009 in the Archives of Internal Medicine called Separate and Unequal, where minority and non-minority patients receive care. And the published papers show that the work conditions in clinics that serve minority patients were substantially more challenging than in clinics that serve mainly non-minority patients. The follow-up abstract that we're presenting shows that the quality of care in some domains is lower in the minority clinics, and that the work conditions are tied in some direct ways to those decrements in quality. And it's the first paper we know that's actually been able to show that quality is related to work conditions, particularly in terms of disparities.
It's so important.
So, this is sort of the beginning of a journey to understand that better. As I mentioned in one of the slides, room availability turns out to be a very important variable. When there aren't enough rooms to see patients in, it's very hard to give out high-quality care. Another variable is just called availability of clinical resources. There was a substantially lower perception that resources were available to minority clinics. And this is a national problem as much as a local problem. But it's something that probably, if we work in health centers, we're well acquainted with these challenges. But I think it's important to be able to acknowledge that these are the challenges that we're facing, and that the desire to push things to a higher level is going to need some of these things to be addressed directly, not just everybody working harder and faster to get there.
Exactly.
We're in conversations right now, Virginia and Sarah and myself and others, about, what would it take to begin to learn more about the specific challenges that are faced in community health centers, and how can we use some of these data and models to improve situations. If we had OWL data and understanding of what the work conditions were, could we target specific interventions to make things better? So what are your thoughts about that, those of you who either work in them or oversee them, about the applicability of some of these issues and variables to your workplaces?
This is Kathy.
A few folks to call in by names, and that would be Kathy and Alan and Deborah. So,
right.
Hello.
One of the things that I've been looking at recently with regards to retention of employees, not necessarily in a medical field, but across the board, is that the things that really increase motivation and less burnout are really very intangible kinds of things. The concepts that don't increase motivation are the real tangible kinds of rewards. And it seems as though with so many of our community health centers struggling financially, that if we could create sort of a cultural shift and get them to look more at the intangible factors that they could create around the work environment, that might be helpful in improving their retention and lessening burnout. Have you noticed any differences there?
Is that Kathy or Deborah?
That was Kathy.
So Kathy, can you say some more about the intangibles, the intangible factors? What have you got in mind?
Well, intangible, I'm thinking more about the kinds of work support things, the work-life support, the flexible schedules, those kinds of things, as opposed to tangible being, hard dollars that are provided for rewards.
Well, I would agree with you that, work support, work-life support, flexible schedules, those are really important. Sarah?
Hey, Kathy, this is Sarah. One of the things I was going to mention around the intangible factors is in our study right now, Healthy Workplace, one of our sites had the research associate go out to the different clinics and present the results, and one of the things that came out of that was people just decided that these were things that they wanted to talk about, their OWL data, like knowing they weren't alone in these struggles really helped, and it actually for at least 6 months or a year, once a quarter, once every 2 months, they got together and just talked about these things and had that at-work support.
Right. Good idea. And, I'm thinking of things like it seems like such a simple concept, but so many of us get busy and forget to do it. Just that direct appreciation and showing recognition for the work that's being done by the clinicians, the mid-levels, and all of the other staff. Those are the kinds of intangible things that cost nothing and yet have such a huge impact on the work environment and the support that an individual feels from the employer. That if we could strengthen our ability to do more of that kind of thing, it would be helpful.
And sometimes just making that a conscious a thought for everyone on staff, just to make that come to the top of the mind a little bit more.
Right. And understanding the importance and the value of it, that it doesn't have to cost a lot.
Right.
They get so focused on we can't afford to do any more,
Yeah.
I think it's very true that the support factor is crucial, and that being intentional about telling people that they're doing a good job. A lot of these things don't cost a lot. One of the first answers we get whenever we speak is, well, that's very expensive. I say, well, some things aren't that expensive at all. It's quite a bit for them. I like the intangible factors. We'll have to keep that word, Kathy. Thank you.
Can you folks hear me? Hi, this is Deborah.
Hi, Deborah.
Hello, Deborah.
Hi. Hello. I work at MSSP, the Multi-Purpose Senior Services Program. We're not a clinic per se, but we provide case management. And the reason I was interested was because in this subject is because we underwent an extremely stressful time a few years back when I came to this agency, where we were taking it on from the county that gave us the contract for it. And we lost a couple of people because of it. And so it's been and a lot of these things that you're talking about that don't cost a lot made a huge difference. And we've lost some funding since then, so we've had to be really creative about how we allocate support for the staff. we have increased caseloads, and we work with people who are elders, who are at risk, and trying to keep them at home, out of institutions. And we have increasing numbers of people who are probably have undiagnosed personality disorders, and so the stress has increased. But a lot of these things have helped that you're talking about in terms of staff support and a lot of just emotional backup, and also staff talking to each other about things and constantly reworking how things can work out well for us.
Back to the demand control model of job stress and look at support on the right-hand side, and what I hear you all saying is that some of these things you don't have to have a line item in the budget for support. You have to go out and give it because people are working hard. They're doing the best with the control they have. Maybe they got 20% control. They'd like to have 80, but they got 20. With enough support and values alignment, that might be all they need to balance their demands.
Well, also the fact that, as we learned, when we came to our supervisors with requests and needs, that they responded quickly to us, so we had some control, made a big difference for us as well.
I'm going to try to repeat what I think you heard. I'm going to repeat what I think I heard you say. When they got more control, when they supported you in getting more control and helped move things forward?
Yes, when they responded to our needs and our requests and demands, that the fact that we felt that we had some control in how things happened did make a difference. It gave us more confidence that we could affect our workplace environment. Does that make sense?
It's a little hard to hear, Deb. I'm sorry. We catch about every sentence.
Oh, sorry.
Not your fault. It's just it's a little echoey there. So.
Okay. Is this better if I keep the microphone closer to my mouth?
So it sounds like we're resonating with issues around control and support.
Yes.
Which
yes.
I find sometimes one of the biggest first steps is just getting the nomenclature down, the glossary of terms, and then trying to be intentional about some of these variables, like thinking about them. See people are stressed, saying, okay, so what could be going on? So would it be helpful to have data, like OWL data, to know about your clinics?
Yes. Yes, it would.
We're going to start that here at Hennepin shortly. We work in a safety net hospital here in Minneapolis, so we're going to start getting OWL data on our departments. And we thought we might start, the proposal is to start with a mini OWL, just sort of get a sample from everybody. We're going to look at the departments that are really doing great and the ones that are really having trouble, and drill down on them with the full OWL, get a much deeper dive into what's going on in those departments. So we'll see how that goes.
Interesting.
Are we able to use your OWL tool? Is it copywritten or anything that we need to get your permission to use, or can we go ahead and pilot it at least with some of our clinics?
We are at the moment engaged in trying to figure out, is there an intellectual property issue in terms of how we do this with the OWL. I'm perfectly happy to have you use it, and just, if we can guide you, it might just be a little bit better because we can show you what to do with the data. But for the time being, yes. If you're on this call and you want to use it, permission granted.
Okay, thank you.
And hopefully, Alan, you'll be a part of the study we've been talking about.
Right.
Yeah, go forward as soon as we can figure out how to fund it.
Right.
Yes, that's right. You may have a lot of opportunities now, so.
Right. Hopefully.
Alan, we should be able to find a way to make that happen. So. Well, it looks like we're closing in on 3 o'clock for us and 1 o'clock for you all, so we sure appreciate your time.
Thank you.
Thank you very much.
Very helpful.
Thank you.